You're listening to Who Said, a cardiology board review series. No fluff, just facts.
This episode is about syncope. We'll go over definitions, presentation, management, and end with a special section on ambulatory electrocardiographic monitoring. Let's start with definitions. What exactly is syncope? Syncope is a syndrome that presents with abrupt, transient, complete loss of consciousness associated with the inability to maintain postural tone, presumed to be due to cerebral hypoperfusion with rapid and spontaneous recovery. How's that different from loss of consciousness and presyncope? Loss of consciousness is a cognitive state in which one lacks awareness of oneself and one's situation with an inability to respond to stimuli. Presyncope are the symptoms that come before syncope. These symptoms could include extreme lightheadedness, visual sensations such as tunnel vision or graying out, and variable degrees of altered consciousness without complete loss of consciousness. Presyncope could progress to syncope, or it could abort without syncope. What exactly do people mean by cardiac syncope and reflex syncope? Cardiac syncope is syncope caused by bradycardia, tachycardia, or hypotension due to low cardiac index, blood flow obstruction, vasodilation, or acute vascular dissection. So you see how cardiac syncope is actually a heterogeneous group of etiologies of syncope. What about reflex syncope? This is also known as neurally mediated syncope. It's syncope due to a reflex that causes vasodilation, bradycardia, or both. The most common form is vasovagal syncope. Vasovagal syncope is the most common form of reflex syncope mediated by the vasovagal reflex. Vasovagal syncope may occur with upright posture, standing or seated, or with exposure to emotional stress, pain, or medical settings. Vasovagal syncope is typically characterized by diaphoresis, warmth, nausea, and pallor. It is associated with vasodepressor hypotension and or inappropriate bradycardia and is often followed by fatigue. Typical features of vasovagal syncope may be absent in older patients. Vasovagal syncope is often preceded by identifiable triggers and or by a characteristic prodrome. The diagnosis is made primarily based on history, physical exam, and eyewitness observation if available. Other than vasovagal syncope, other common types of reflex syncope are carotid sinus syndrome and situational syncope. Carotid sinus syndrome is reflex syncope that is associated with carotid sinus hypersensitivity. Carotid sinus hypersensitivity is present when a pause of at least 3 seconds and or a decrease of systolic pressure of at least 50 millimeters mercury upon stimulation of the carotid sinus occurs. It is more frequently found in older patients. Situational syncope is reflex syncope that is associated with a specific action such as coughing, laughing, swallowing, micturition, or defecation. These syncope events are closely associated with specific physical functions. What about unexplained syncope and psychogenic pseudosyncope? Unexplained syncope is syncope of undetermined etiology. Syncope for which a cause is undetermined after an initial evaluation that is deemed appropriate by the experienced healthcare provider. The initial evaluation includes but is not limited to a thorough history, physical examination, and ECG. Psychogenic pseudosyncope is a syndrome of apparent but not true loss of consciousness that may occur in the absence of identifiable cardiac, reflex, neurologic, or metabolic causes. Now let's move on to presentation. There are several high-risk features for which you need to further investigate syncope and possibly admit: abnormal EKG, history of structural heart disease or heart failure, systolic blood pressure less than 90, shortness of breath during syncope, hematocrit less than 30, advanced age with cardiovascular comorbidities, and family history of sudden cardiac death. These are the high-risk features where if you have one or more of them, you need to further investigate the syncope and possibly admit. Features suggesting that a syncope is from an arrhythmogenic cause are absence of a prodrome, brief duration, syncope during exertion, palpitations at the time of syncope, and family history of sudden cardiac death. ECG features suggesting a high risk for ventricular arrhythmias include short or prolonged QT interval, Brugada pattern, negative T waves in the right precordial leads, and pathologic Q waves. Exertional syncope is concerning for a malignant cause, such as HOCM, hypertrophic obstructive cardiomyopathy, anomalous coronary arteries, long QT syndrome, or CPVT. Vasovagal attacks, which is the most common cause of syncope, is due to peripheral vasodilation after prolonged standing or intense pain. It is preceded by dizziness and nausea and will have a normal ECG. The prodrome of nausea, pallor, diaphoresis, and generalized warmth before vasovagal syncope persists for a brief period after the episode. Loss of consciousness almost never occurs in TIA, unlike in vasovagal syncope. TIA is characterized by the abrupt onset of numbness, weakness, and vision loss. TIA symptoms gradually resolve and usually last under an hour. Brain CT or MRI should not be ordered in a syncope patient who has a normal neurologic exam. Migraines usually consist of positive symptoms, meaning visual disturbances, scotoma, or geometric patterns. Migraines will last for 20 to 30 minutes and are often accompanied by headache, nausea, and vomiting. Loss of consciousness almost never occurs in migraines, unlike in vasovagal syncope. Vertebral artery dissection has headache, dysarthria, dysphagia, gait unsteadiness, and vision loss. Those are some of the other differentials that you think about with syncope. The prognosis of patients with non-cardiac syncope tends to be benign, whereas the prognosis of patients with syncope of cardiac origin is not benign, with a 1-year mortality rate of 30%. The three most common arrhythmic causes of syncope are sinus node dysfunction, atrioventricular block, and tachyarrhythmias. Of the three, tachyarrhythmias are most reliably initiated in the EP lab, followed by sinus node abnormalities and AV block. Cardiogenic syncope is not a specific diagnosis, as I mentioned earlier. There are many things that comprise the bucket of cardiogenic syncope. Here are some clues for the intra-diagnosis of cardiogenic syncope. Exertional syncope or systolic murmur on physical exam suggests you might have aortic stenosis or hypertrophic or obstructive cardiomyopathy, which you need to investigate. If there's no preceding symptoms whatsoever, and the patient has a history of cardiomyopathy or previous MI, then you need to investigate for ventricular tachycardia. If the patient has preceding fatigue or dizziness and sinus pauses on ECG, then you need to investigate sick sinus syndrome. If the patient has bifascicular block on ECG and dropped QRS complexes, you need to investigate advanced AV block. If there's no preceding symptoms, presence of medications that prolong QT interval, and hypokalemia or hypomagnesemia, then you need to look for torsade de pointes. Stokes-Adams attack is syncope from second degree type 2 AV block or from complete heart block. A carotid sinus massage diagnoses carotid sinus hypersensitivity as the etiology of syncope if the patient develops syncope along with asystole for at least 3 seconds and or if there's a fall of systolic blood pressure by more than 50 millimeters of mercury. No additional workup is needed for diagnosing carotid sinus hypersensitivity. You're not allowed to do carotid sinus massage in patients with ipsilateral carotid artery stenosis or carotid bruits or a history of TIA or stroke in the last 3 months because you risk causing an iatrogenic embolization leading to stroke. Patients will syncopize when they get pressure on the carotid sinus from a tight collar and neck movements while getting dressed in the morning or from shaving the neck area. The treatment of carotid sinus hypersensitivity syncope is permanent pacing. Now, in terms of management, what does the 2017 ACC-AHA-HRS guideline for the evaluation and management of syncope tell us about vasovagal syncope? First things first, patient education on the diagnosis and prognosis of vasovagal syncope is recommended. That's a class 1 recommendation. Physical countermaneuvers can be useful in patients with vasovagal syncope who have a sufficiently long prodromal period. Class 2A. Midodrine is reasonable in patients with recurrent vasovagal syncope with no history of hypertension, heart failure, or urinary retention. Class 2A. The usefulness of orthostatic training is uncertain in patients with frequent vasovagal syncope. Class 2B. Hydrocortisone might be reasonable in patients with recurrent vasovagal syncope and inadequate response to salt and fluid intake unless contraindicated. Class 2B. Beta blockers might be reasonable in patients 42 years of age or older with recurrent vasovagal syncope. Class 2B. Encouraging increased salt and fluid intake may be reasonable in selected patients with vasovagal syncope unless contraindicated. Class 2B. In selected patients with vasovagal syncope, it may be reasonable to reduce or withdraw medications that cause hypotension when appropriate. Class 2B. In patients with recurrent vasovagal syncope, a selective serotonin reuptake inhibitor might be considered. Class 2B. Now, a very common question that we get from patients and families is, what is the symptom-free waiting time before an individual can return to driving after an episode of syncope? Please note that what I'm about to tell you is listed in the 2017 ACC/AHA HRS guideline for the evaluation and management of syncope, and that local state laws take precedence and will vary everywhere, so you need to check and correlate with the local state laws, which take precedence. For orthostatic hypotension, in general, you need a 1-month symptom-free waiting time before an individual can return to driving after an episode of syncope. For vasovagal syncope, which is the most common kind, if they have had more than 6 episodes of syncope per year, they are not fit to drive, period. If they've had 1 to 6 episodes of syncope per year, they need a minimum of a 1-month period without having syncope before they can return to driving. For vasovagal syncope, where they have had 1 year without any episodes of syncope, then they have no restriction anymore. They can drive whenever they want. For carotid sinus syncope, if it's untreated, they're not fit to drive. If they've received a permanent pacemaker, they can drive 1 week after the pacemaker. Same for syncope due to non-reflex bradycardia. If it's untreated, they're not fit to drive. If they've been treated with a permanent pacemaker, they can drive in 1 week. For syncope due to supraventricular tachycardia, if they have not been treated, they are not fit to drive. But if they've been pharmacologically treated, then 1 month without syncope episodes and they can drive. If they have been treated with ablation, they can drive 1 week after the ablation. For syncope with heart failure, ejection fraction less than 35%, and an presumed arrhythmic etiology, if they don't have an ICD yet, they're not fit to drive. If they have an ICD, they can drive in 3 months. Syncope, presumed due to VT or VF or structural heart disease, and ejection fraction that is above 35% inclusive. If they have been untreated, then they are not fit to drive. But if they've been treated with an ICD and GDMT, then they can drive in 3 months. Please note there are many more scenarios. I just presented you with a selection of what I think that you will encounter most commonly. Now, let's finish with a special section on ambulatory electrocardiographic monitoring. According to the 2017 ACC/AHA HRS guideline for the evaluation and management of syncope, the choice of a specific cardiac monitor should be determined on the basis of the frequency and nature of syncope events. Class 1. To evaluate selected ambulatory patients with syncope of suspected arrhythmic etiology, the following external cardiac monitoring approaches can be useful: Holter monitor, transtelephonic monitor, external loop recorder, patch recorder, and mobile cardiac outpatient telemetry. Class 2A recommendation. To evaluate selected ambulatory patients with syncope of suspected arrhythmic etiology, an implantable cardiac monitor can be useful. Class 2A. Does this all sound like a jumble of the same thing? Not to worry. We will sort out the differences between these similar device classes right now. We'll talk about Holter monitor, then a post-event monitor, which is just abbreviated as event monitor, then an external loop recorder, then mobile cardiac telemetry, then a patch monitor, such as the iRhythm patch, then SmartTech ECG, such as a LiveCore CardioMobile. Then we'll talk about the invasive type and implantable loop recorder. So let's start with the Holter monitor, which is one of the oldest, designed in the 1950s. Of course, since the 1950s to the 2020s, there has been a significant reduction in the size of these devices and the features associated with it. But the principle remains the same. So Holter monitor is a device with 3 to 12 ECG leads, not just one lead. It has 3 to 12 ECG leads. The duration of recording is 24 to 48 hours, and it can be extended up to 2 weeks with the newer models. The indication is for frequent symptoms, i.e. daily occurrences, that need to be detected within a short period of monitoring, 24 to 48 hours. The advantages of Holter monitor are that it allows for continuous full disclosure recording up to 12 leads, physician familiarity, and is good for daily symptom correlation. Limitations of Holter monitor is that the short duration of 24 to 48 hours may miss infrequent arrhythmias, and it requires patient event diary for symptom correlation. It also requires wires and gel electrodes, which limits the patient's physical activity and may be inconvenient, and you only have a post hoc analysis. The cost is cheap relative to the other devices. Next, a post-event monitor, or also known as just an event monitor. This is a leadless device that is held to the chest during symptomatic episodes. It can be up to 30 days because you're doing intermittent recording. And the indications are frequent spontaneous symptoms likely to recur within a few weeks. The advantages of an event monitor is that it gives the healthcare provider and patient real-time data transmission during symptomatic episodes with extended observation. Limitations are that the post-event monitor requires patient activation, records only select sequences, and it has limited use in patients with sudden incapacitation, syncope. So when you do something like a post-event monitor, which requires bringing the device to the chest during symptomatic episodes, it's only going to work if the patient is not getting suddenly incapacitated from a syncope and being conscious enough in order to do it. Now, next one is the external loop recorder. This one is also 3 to 12 leads attached by wires, just like the Holter monitor, with intermittent recording based on a patient or auto trigger. The patient activation before or after an event allows for symptom rhythm correlation. However, some external loop recorders are of limited use in patients who are temporarily incapacitated around the time of syncope, just like for the post-event monitor. The duration is up to 30 days with continuous observation. This is in contrast with a post-event monitor, which is up to 30 days with intermittent recording. The indications of the external loop recorder are recurrent spontaneous symptoms potentially related to bradycardia or conduction disorders. Advantages of the external loop recorder are multi-channel recording because you have 3 to 12 leads, get extended observation during the 30 days, unlike the post-event monitor, which gives you intermittent recording over the 30 days, and backward memory, so it allows you to record events before and after, not just right after the patient activation. Since for the external loop recorder, it's continuously recording in a loop and then it just erases the memory when it runs out of memory, but it's continuously recording so that when the patient activates, it will save the sequence just before the activation and the sequence after the activation. Whereas with the post-event monitor, it can only record the sequence after the patient activation. Limitations of the external loop recorder are that wires and gel electrodes are necessary, so it's somewhat inconvenient for patients who want to engage in physical activity, just like the Holter monitor as well. And it also records selected sequences, so you're relying on the patient to identify which the selected sequences are. The external loop recorder is slightly more expensive than a post-event monitor and Holter monitor, which understandably so since it's doing continuous observation for the 30 days. Next, we have mobile cardiac telemetry, or MCT. This is a device with 3 leads with continuous transmission to a portable monitor, and the data is wirelessly sent for analysis. The duration can be 1, 2, 3, or 4 weeks, and the indications are high-risk patients requiring real-time rhythm analysis. For example, if you need to detect ventricular tachycardia or brief subtle arrhythmias. This is real time. So when this happens, when the patient's getting some VTAC, the healthcare provider gets an alert in real time that this patient's having VTAC. So this is the main advantage. It gives you real-time rhythm analysis, allowing you to call the patient and ask them to come to the ED. It also gives you extended observation. This is continuous recording. The limitations is that it does require significant human resources for continuous monitoring. So this relies on having somebody at the company and somebody at the hospital who is continuously on call to receive these alerts for any VTAC that occurs on this live transmission wirelessly. And as expected, the mobile cardiac telemetry is more expensive than external loop recorder, which is in turn more expensive than the post-event monitor and Holter monitor. These days, we have a lot of patch monitors. I find that patch monitors are actually more common than any of these other devices that I mentioned above because patients love the small nature. These patch monitors are a single leadless patch affixed to the chest. So it's basically like a sticker. They don't need to have wires sticking out anywhere. It's just a sticker they place on the chest. These last for 2 to 4 weeks and they do continuous recording, and they are indicated if symptoms are moderate in frequency or if you have suspicion for asymptomatic low-risk arrhythmias. The reason why we say asymptomatic low-risk arrhythmias is because these patch monitors do not necessarily transmit the data live wirelessly, and the patient often needs to ship it back in a box for analysis by the company. Just like all the other devices above, other than mobile cardiac telemetry. Mobile cardiac telemetry is the only one of the ones that I told you so far where the patient doesn't have to wait to ship it back in a box before the healthcare provider can get any notifications about their arrhythmias. So advantages of the patch monitor are that they're leadless, it's ergonomics, water resistant, full disclosure recording, good for patient adherence. The patient barely feels it. They can go about their daily life and even do physical activities. Limitations of the patch monitor are that it's only single channel and post hoc analysis is required, like I mentioned. The cost is actually less expensive for patch monitor compared to mobile cardiac telemetry because you're not paying for that wireless instant transmission and instant rhythm analysis with the alerts for the VT. These days, smart tech ECG is becoming very popular with patients, such as the AliveCore CardioMobile. These are external sensors, single lead ECGs recorded through a smartphone or smartwatch. The duration are 30-second recordings and they are patient activated. Indications are intermittent, low-risk, non-debilitating symptoms like palpitations in low-risk patients. The advantages are that smart tech ECGs are widely available. They are easy to use and automated, and they come with automated atrial fibrillation detection. The limitations are that you don't have continuous observation. You have to wait for the patient to place it on themselves, so they need to initiate placing them themselves and do this single lead recording, the patient activation, and then it gets transmitted. So you do have live transmission, but only if the patient initiates it, which means that if the patient suddenly syncopizes, they're not going to be able to go and stick this smart tech ECG device on themselves to transmit that rhythm. So it's more for low-risk patients in the home setting. Finally, we have the invasive option, which is the implantable loop recorder. Design is a subcutaneously implanted device in the left parasternal region of the chest, and it allows you to do continuous recording for up to 3 years. So this is very long. Everything that I've talked about so far does up to 4 weeks of continuous recording, but the implantable loop recorder can sit in there and record for up to 3 years. Indications for implantable loop recorder are infrequent, unexplained symptoms potentially related to arrhythmias after an initial non-diagnostic workup. Advantages of the implantable loop recorder are that it allows for long-term monitoring and has automated arrhythmia detection. Limitations of the implantable loop recorder is that it requires surgical implantation and it is of high cost. The implantable loop recorder is more expensive than everything else that I've told you about so far, including the mobile cardiac telemetry. And understandably so, because this is basically, it's like a surgery that to implant this device into the patient's chest, and it's there for 3 years. It's continuously recording for 3 years. So that's what you're paying for. To summarize, your decision making based on duration or symptom frequency for which device to use in a patient that you want to do rhythm monitoring for. Holter monitor is for short term. That's just 24 to 48 hours. Monitoring for frequent symptoms. For example, if you have palpitations or fainting episodes that are happening daily or multiple times a day, then this 24 to 48 hour period is enough. Post-event monitor is for intermittent monitoring for infrequent symptoms occurring over a few weeks. External loop recorder is for continuous observation with intermittent recording for recurrent arrhythmias over weeks. Mobile cardiac telemetry is for continuous real-time monitoring for high-risk arrhythmias needing immediate intervention. So it's the one where if the patient has VT, you want to detect it right away, transmit that wirelessly to the person on call, and have them call the patient to come into the ED for therapies. That's mobile cardiac telemetry. Patch monitor is the very popular one these days, continuous monitoring in patients who need longer periods of observation but do not require real-time data. So you can just give them the sticker on the chest, and then after 1 to 4 weeks, they can send in that sticker for post-hoc analysis. Then you have the SmartTech ECGs, which are for low-risk occasional symptoms where brief intermittent recordings that are patient-initiated are adequate. Finally, you have the loop recorder that's implantable, ILR. This gives you long-term monitoring for very infrequent or unexplained symptoms over months to years. So now we have gone over definitions, presentation, and management of syncope, as well as ambulatory electrocardiographic devices.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.